This is a reminder for you of the choledochal cyst. The type 1 has a dilatation of the bile duct. The type 2 has a little diverticulum, a little cyst, off the bile duct. Type 3 has a little choledococele protruding into the duodenum. Type 4 has dilated biliary ducts throughout the liver looking like small cysts, and it also has an associated fusiform dilatation of the common bile duct. And type 5, or Caroli's disease, has the dilated intrahepatic ducts but no dilatation of the common bile duct. So these types you can see, and it's these two that would have dilated cystic type structures in the liver. Complex cystic masses. What about cystic masses with echoes inside of them? Well, that could be from a hemorrhage within a cyst. It could be from infection in a cyst. It could be a hematoma in the liver, could be an abscess in the liver. Notice that there's sound through transmission, so we know that this is of a cystic nature. In this case, this was an abscess. It could be a biloma or seroma, could even be a large biliary cystadenoma, or could be cystic or necrotic degeneration within a metastasis or a malignant tumor. Liver abscesses sometimes cause trouble in diagnosis. A liver abscess, when it has fluid and debris, is fairly easy to spot, but when it has bubbles of gas or pockets of gas, that sometimes may shadow out the back wall of the abscess itself and may cause confusion in its appearance. Here's another way that an abscess can confuse us. An abscess completely filled with pus can be echogenic and sometimes look isoechoic with the liver, and it may actually mimic liver and you may not recognize it. But your eye then would catch some effect on a vessel. Perhaps you may catch an edge effect from the curved surface, and you would eventually realize that there is an abscess here within the liver. This is a fairly characteristic appearance. If you saw a cystic mass in the liver and you saw this kind of folding membrane referred to as the lily pad sign, this is the sloughed internal membrane folding in upon itself, very characteristic of an echinococcal cyst. If you see this, you may be the first one to suggest this diagnosis. Patients travel these days to various parts of the world and may bring back a souvenir, an echinococcal cyst, and nobody may think of it until the characteristic sonographic picture is presented. Other complex cystic masses can occur. We can have benign, we can have malignant. This happens to be metastases that are complex cystic lesions. This one is an echinococcal cyst with internal debris. This one, metastases. So we can't really tell, there's nothing specific. So that's why I'd like to make just a list of hypoechoic masses in the liver. Nothing very specific about these. We can have an abscess, we can have an adenoma, focal nodular hyperplasia, a hemangioma, an unusual atypical hemangioma, focal fatty sparing, microabscesses. They can be hypoechoic. It could be a malignant metastasis, hepatocellular carcinoma, or lymphoma. We can't tell. This happened to be a case of focal nodular hyperplasia, this should be hyperplasia, and this was proven by MRI. We see in the literature that focal nodular hyperplasia has a central scar. However, this is not diagnostic. It's fairly characteristic, but it is not diagnostic. And here's why I'd like to show you. Here's a lesion with a central scar, and this was a hepatocellular carcinoma. This was a lesion that seemed to have a central scar, and this ended up to be a giant hemangioma. So you see, even that central scar is not characteristic enough to be 100% diagnostic. We also have lesions in the liver that are homogeneous and hyperechoic, and most of the time they are hemangiomas. Both of these are, but we have to be very careful. There are other lesions that can look exactly like this that are not hemangiomas. Hemangiomas, when they are found incidentally in asymptomatic patients and in a young patient, a patient under 40, well, such a lesion we can call a hemangioma if it's under 3 centimeters. But if the patient is older, beyond 40, or if the patient has any other medical illness, we have to then prove this to be a hemangioma. Let me show you some atypical hemangiomas. This is hemangioma atypical, heterogeneous. This one has some cystic spaces. This one is not totally hyperechoic. This one is hypoechoic and has some sound transmission. All of these are hemangiomas, but they're not typical. Now let's look at something hyperechoic. What's the differential of a hyperechoic lesion in the liver? Well, we all know about hemangioma, but it could possibly be an abscess. It could be an adenoma, could be focal nodular should be hyperplasia. It could be focal fat, could be a hemorrhagic cyst. And it could also be something malignant. Could be a metastasis, could be a hepatocellular carcinoma, could be lymphoma. Not very specific. All of these are unusual, but this one happens to be a thyroid cancer metastasis. So you see, nothing is 100% in the liver. Now, when we talk about multiple solid masses in the liver, the differential diagnosis is metastasis, metastasis, metastasis. But there are other pathologies that can mimic this, that can be just the same. Usually we would say metastasis and we would want to have a history to see what's going on. But it's still, even in this case, not 100%. We can have regenerating nodules in a liver in cirrhosis like this patient had, and this patient has lymphoma, masses within the liver. So even solid metastases are not 100%. Here's another patient with multiple focal hypoechoic masses, and this was multiple atypical hemangiomas. And this one with small hypoechoic masses was microabscesses in an immunocompromised patient. So multiple hypoechoic solid masses is not always metastatic disease. Some metastases are calcified, and we usually think of them as coming from colon cancer, but there is a whole laundry list of other cancers. We can see calcified metastases with ovarian cancer, breast cancer, stomach cancer, pancreas, osteosarcoma, leiomyosarcoma, chondrosarcoma, teratocarcinoma, so certainly not a specific appearance. What's very useful with sonography is that when we're not sure we need a tissue diagnosis, we can just guide a needle straight into the mass and get a biopsy, or provide drainage if it's an abscess, and that's extremely useful. Before I close, I just would like to remind you that when you have a case of liver metastases, you should always think a little further to see, are those metastases causing any complications, such as segmental biliary obstruction. You should double check the vessels. Are the metastases invading vessels? Is there invasion of the portal vein? Is there invasion of hepatic veins? This is a patient who has hepatocellular carcinoma in the left lobe, and tumor has grown into the main portal vein, tumor thrombus. You should look for necrosis, maybe hemorrhage or some kind of superinfection. These are all possible complications of liver metastases. So in conclusion, we have discussed the appearance of the normal liver. We've talked about normal and abnormal Doppler patterns of hepatic vessels. We've covered diffuse liver disease patterns. We've talked about portal hypertension and discussed focal liver metastases. Thank you for your attention.